Hi everybody. This is the final presentation. I'm going to kind of go through this stuff a little quicker. This is in regards to the assessment piece of the abdominal assessment. There was a couple of slides that I had put into the newer PowerPoint, and because I had previously recorded this presentation, or the presentation, I hadn't included these two slides. So I'm just going to touch on them really quick, and just so that you know. So you probably scrolled past them when you were watching the other presentation. And this is just giving you a rundown of what anatomy is found in each of the four quadrants of the abdomen. So this comes from your book. I don't have a page number, but it comes from your book, so you can look these things up. But I want you to know these things. I want you to know what is found in the four upper quadrants, because it's very likely that I would ask you on a test, where is the gallbladder found, and you would say right upper quadrant. What is, where would you find the spleen? Left upper quadrant. So I want you to know these areas. So it's this slide and the next slide. The uppers are on the previous one, and then the lower quadrants are on this slide. So make sure that you know these things, and again, they are in your book as well. All right, then we also have midline organs, which are kind of in the middle. The aorta, the uterus, and the bladder, but mostly focus on those ones that are found in the four quadrants. All right, and you had all of this on the last one, so I'm going to skip through to this slide. So subjective data. This is focusing on the exam piece specifically. Subjective data, you can look at pages 542 through 545. These are the questions that you're going to be asking about. Appetite, dysphagia. Now remember, this dysphagia is difficulty in swallowing. Dysphagia with an S instead of a G, that's where they have difficulty speaking. So this is the one where they have difficulty swallowing. And then the rest of the things that you can look at here. In preparing them for the exam, making sure you have a good light source and a stand light. And when you get into lab, you'll see why. We're going to use that tangential lighting where it's coming in from the side. So bringing the lamp down to the level of the person's abdomen and shining it across, looking for any abnormalities. Making sure that you are able to see the abdomen, the entire abdomen, drape the patient appropriately, making sure they're positioned for comfort. It's often nice if you can put not only the pillow under their head, but pillow under their legs, under their knees as well, so that they can be fully relaxed. Always have them empty their bladder before you start pressing around on their abdomen. If you think that you may need a urine sample, make sure you get that before you, have them empty their bladder. Make sure the stethoscope is warm before you put it on. And this is important where it says examine the areas identified as painful last, so that you can prevent that guarding. And we talked about guarding in the previous slides before, in the previous presentations. So if they say they have lower right quadrant pain, you're not going to examine that until the very end, because they're going to tense up, and that's going to cause problems with the other areas of the abdomen as well. Auscultate before palpation and percussion. So we know that typically we go in a particular sequence when we look at inspection and palpation and auscultation, percussion. However, with the abdomen, we don't want to start pressing around on the belly, because it can stir things up, and it can irritate the bowel, and it can increase bowel sounds and increase peristalsis of the colon. So it's important to do auscultation before you start doing palpation and percussion. Use distraction if you need to keep the patient relaxed. Inspection Looking at across the abdomen, look at page 546. These pictures are in your book. It shows you the different types of abdomen. If you look at the scaphoid, or the flat abdomen, that's what we would normally expect. Scaphoid is where it's really kind of sunk in, and those are those people who are very thin, maybe anorexic. Rounded, just a gentle rounding, versus protuberant, where the abdomen is sticking out quite a bit. Symmetry, again, shining that light across the abdomen so that you can see everything should look symmetric bilaterally. Their belly button, their umbilicus could be inverted, meaning an innie instead of an outie, or an outie instead of an innie. So make sure you know the direction of that, but the umbilicus should be midline. Looking for the skin, just as we always have, inspecting, looking for those pulsations. We know that when we did the lungs or the chest area, the heart examination, we said we might see pulsations in the epigastric area, so looking for that. Looking at hair distribution. When you listen to, and back to that slide, if you happen to see a scar, ask about it, and ask them how they got the scar, why they have the scar there, what surgery, did they have surgery, or was it from something else? The reason it's important to ask about scars is that underneath the scars we can get things called adhesions, which are excessive fibrous tissue underneath there, and they can be painful. They can cause some problems. Sometimes people have to have surgery because they develop so many adhesions. So it's good to know if they're having certain problems, if they've had this surgery. All right, auscultation. This is where you're going to use the diaphragm part of the stethoscope to listen. And sorry, I'm just trying to find my slide. Hold it lightly against the skin, because as we said, you don't want to press down and increase the peristalsis in that area. Start in the right lower quadrant, and asking you why. And the reason is, if in class I would wait and have you answer, but the reason is in the right lower quadrant is the ileocecal valve, where the ileum and the cecum meet together, and you almost always will hear vowel sounds in that area. So it's a good place to start so that you can hear what normal vowel sounds sound like, and then move into the other areas. Listening to the vowel sounds, you want to know the character of them and how often you have them. They are very high-pitched gurgling sounds. They can occur anywhere from 5 to 30 times per minute. You don't need to count them, okay? Just want to make sure that we have a minimum of 5 per minute. That could be considered hypo. They're not as many as we would expect them to have. They're hypoactive versus hyperactive. So 5 would be hypoactive, 30 would be hyperactive, and we would expect somewhere in the middle. Hypoactive, people may have this just because of maybe they just had surgery in the area, and the vowel sounds haven't returned. The activity of the area hasn't returned to normal yet. Silence is not normal. Before you move on, before you say that you haven't heard vowel sounds or you've determined that they're hypoactive, you want to listen for a full 5 minutes. Now, what we normally do is we listen for a minute in each quadrant, but total time, you want to listen at least 5 minutes before you determine that there are no vowel sounds. So not 5 minutes in each quadrant, but 5 minutes total. But otherwise, you only listen until you actually hear a sound, and then you can move on to the next area. And we'll learn more about that in lab. And you may hear vascular sounds as well, and think about where your arteries run. That's where you may hear those vascular sounds. So the areas over the femoral arteries, the iliac arteries, and of course over the aorta. And then we also have arteries connecting into the kidneys, so the renal arteries. If your patient has hypertension, high blood pressure, you may hear these sounds over these vascular sounds over these arteries even more. And listen again if you hear any of the bruits that we have talked about. When you percuss, the normal sound that you would hear, so again, that's that tapping, and the predominant sound is called tympany. Now, when you were in the lungs, we said it was resonance, so now it is tympany. This is caused by air in the intestines that rises to the surface when the person is laying on their back. And you also may hear dullness over organs. So you should hear a nice hollow sound over everywhere except if they have a distended bladder, if they have a lot of fatty tissue, if there's any masses or fluids, and of course if they're going over any of those solid organs versus the hollow organs. The CVA, the costovertebral angle, this is the area on the back. So if this is the person's spine, and you can feel the rib cage coming off here, the angle between where that rib cage is and the spine, this area here, that's the costovertebral angle. You're going to place your hand over that area and give it a large thump. Not real hard, but just a thump. And they should feel a thud, but they shouldn't feel any pain. Pain is a sign that there's some kind of a kidney disease or kidney issue. Palpation, our patient could be ticklish, they may have pain, they may have guarding, they may have rigidity. Look at page 554, it tells you how to get past some of those things to enhance muscle relaxation. Start with a light touch, going in that circular motion, just to get that overall impression of the skin and musculature. And again, remember to avoid those painful areas until last. Deep palpation, this is where you would press down about 2 to 3 inches. Now, if you need to, especially if the person is larger, you may want to use the bimanual technique where you have one hand out and the other hand pressing down so that you can really push deep to feel all of those organs. Person has a really large abdomen or they're obese, this is where that will come in handy. All right, light and deep palpation, you could read through all of these. These are the things, if we have any masses, just like before, let us know, describe them. Aging adult possible findings, we talked a lot about these already in lecture, but looking for aging adult findings, they may have more subcutaneous fat on the abdomen and the hips. The musculature is thinner. The organs may be easier to palpate just because they have that thinner abdominal wall. Liver's easier to palpate if you're doing that. And of course the kidneys can be easier to palpate as well. Abnormal findings, so this is on page 567 in your book. I'd like you to just kind of look through these things on your own. Obesity, these are the things that you might see with obesity when you're doing each part of the examination, the inspection, percussion, palpation, and so on. This is a picture of a lot of gas built up in the abdomen. This might be something that you would see. Patient comes in and they may have a real rounded or curved abdomen. You may not be able to hear very well just because of the excess gas in there. You still should hear tympany when you percuss, but they may have some more pain and some spasms of the abdominal wall. Here is ascites, so this is a fluid buildup in the abdomen. This would be where the belly button is, right in this area here. So you can see that it's really quite a distended abdomen, and this describes the different findings that you might see. Ovarian cysts, women can get ovarian cysts. They may have some problems with that, especially pain, and you can look through these things on your own. All of this white in this x-ray is stool built up in the colon, and these are the things that you might find when you're doing examination with someone who has either blockages or just a large buildup of stool. And then a tumor, these are the findings when you're doing all the examination pieces that you might see. All right, intestinal obstruction, you can read over this on your own on page 569. You would expect to have hyperactive bowel sounds above the obstruction, and they might be absent below it. And then